Hello everyone. Now we will be studying about placenta previa. It is one of the very important causes of antepartum hemorrhage and also the very important topic for MBBS final year in the obstetric and gynecology examination. So moving forward, what is placenta previa? It is the condition when the placenta is implanted partially or completely over the lower uterine segment over and adjacent to the internal os, and it is called as placenta previa. So I will repeat again. When the placenta is implanted partially or completely over the lower uterine segment over and adjacent to the internal os, it is known as placenta previa. And the term previa denotes the position of placenta in relation to the presenting part. And it talking about incidence. So before etiology, we'll shortly talk about incidence. So 1/3 of cases of antepartum hemorrhage belong to placenta previa. Almost as we have discussed in previous video, the incidence of placenta previa range from 0.5 to 1% amongst the hospital deliveries, and in 80% of the cases it is found in multiparous women, and the incidence is increased beyond the age of 35 years, smokers, and in the multiple pregnancy. Increased family planning acceptance with limitation and spacing of the birth lowers the incidence of placenta previa. So talking about etiology, the exact cause of implantation of the placenta in lower uterine segment is not known, but there are various different theories that have been postulated to explain the cause of placenta previa. One is dropping down theory. According to this theory, the fertilized ovum drops down and is implanted in the lower uterine segment. The poor decidual reaction in the upper uterine segment may be the cause. So the fertilized ovum might drop down, and the failure of zona pellucida to disappear in time can be a hypothetical possibility. And this explains the formation of central placenta previa. And in the next theories, we have the persistence of chorionic cavity in the decidua capsularis and its subsequent development into capsular placenta, which comes in contact with decidua vera of the lower segment, can explain the formation of lesser degree of placenta previa. And in defective decidua, it results in spreading of the chorionic villi over the wide area of the uterine wall to get nourishment. And during this process, not only the placenta becomes membranous, but also it encroaches onto the lower segment. And such placenta previa may invade the underlying decidua or myometrium to cause placenta accreta, increta, or percreta. And next is the big surface area of the placenta hyperplacentation, as in twins, might lead to the as may encroach into the lower segment, and that might lead to placenta previa. And the rise of placenta previa increases with the number of prior cesarean delivery. The placenta previa occurs in 0.9% of the women with one prior cesarean delivery, and 3% women with more than 3 cesarean delivery. So placenta previa increases with the number of previous cesarean delivery. So now talking about risk factor for placenta previa. So there are various different kind of risk factor. Around 12 causes I have listed here. First one is the multiparity. The more the parity, more is the risk of the placenta previa. Increased maternal age, more than 35 years. Race, Asian women is more likely to have placenta previa. And the maternal factor like infertility treatment, and the pregnancy following assisted reproductive technology due to infertility. So this might lead to placenta previa. Next we have cause due to multiple pregnancy. In this condition 6, 7, 8, there is large placenta, and that leads to placenta previa. Suppose in multiple pregnancy there is large placenta, and placental size and abnormality like sustenturate lobes, big placenta, smoking. And how smoking can cause placenta previa? Because it causes placental hypertrophy to compensate carbon monoxide induced hypoxia. And here, prior cesarean delivery or uterine surgery, presence of uterine scar, again cesarean section, myomectomy, hysterotomy, prior curettage, and prior placenta previa. All these causes prevention of placental migration, and these may cause placenta previa. So these are all risk factor for the placenta previa. Now, what are the types of or degree of placenta previa? The recent newest classification is given by ACOG or ACR in 2014, and according to this classification, we have just two types of placenta previa. One is true placenta previa, that is the placenta that covers the internal os. You can see the placenta covers the internal os, and the low-lying placenta, the placenta lies within 2 cm of internal os but does not cover it. It lies within the 2 cm from the internal os but does not cover it. According to older classification, we have 4 type of placenta previa: the type 1, type 2, type 3, type 4, or stage 1, 2, 3, 4. And let's see the picture of this. Here we can see the 4 different stages of placenta previa according to the older classification. In stage 1, the placenta is in lower uterine segment but does not reach until the level of internal os. In stage 1, it doesn't reach up to the internal os. It is within the 2 cm of internal os. And in stage 2, it is also known as the marginal placenta previa. Stage 1 is known as the lateral placenta previa. In the marginal placenta previa, we have the placental edge reaches the margin of internal os but doesn't come in. It does not cover it. So placenta reaches the margin. You can see the placenta reaches the margin but doesn't cover it. But in stage 1, it is within the 2 cm of internal os, and this corresponds with the low-lying placenta in the newer classification. And this is, it reaches the stage internal os but does not cover it. And here in stage 3 or type 3, the placenta covers the internal os but only partially. It covers the internal os but only partially. And in type 4, the placenta covers the internal os completely, as we can see. So this is grade 1, grade 2, grade 3, and grade 4 of the placenta. So that was the type 1, type 2, type 3, and type 4, and we have discussed it. So what is the cause of bleeding in the placenta previa? So let's discuss in short. As the placenta growth slows down in later month and lower segment progressively enlarges, the inelastic placenta is sheared off the wall of the lower segment, and this leads to opening of the uteroplacental vessel, and it leads to an episode of bleeding. As it is a physiological phenomenon which leads to the separation of the placenta, the bleeding is said to be inevitable. However, the separation of the placenta may be provoked by trauma, including vaginal examination, coital act, and external version, or during high rupture of membrane. The blood is almost always maternal, although fetal blood may escape from the torn villi, especially when the placenta is separated during trauma. And the mechanism of spontaneous control of bleeding is that due to thrombosis of open sinus, mechanical pressure by presenting part, and the placental infarction. And next we have something known as placental migration. What is it? The ultrasonography at 17 weeks of gestation reveals placenta covering the internal os in about 15% of the cases. Placenta covering the internal os in 15% of the cases. The repeat ultrasonography at 34 weeks shows that there is no placenta in the lower uterine segment in more than 90% of the cases, and the lower uterine segment expands from 0.5 cm at 20 weeks to more than 5 cm, around tenfold at the term. So the term placental migration is a misnomer, and it could be explained in 2 ways. With the progressive increase in the length of lower uterine segment, the lower placental is relocates away from the cervical os, and due to the trophotropism, that is the growth of trophoblastic tissue towards the fundus as it is more vascular, there is resolution of placenta previa. So the placenta previa might resolve if it is seen in early pregnancy, like in 17 week or 20 week. So that is one. So what are the clinical features? It is easy to remember, as the only symptom of placenta previa is the vaginal bleeding. So classic feature of bleeding is in the placental previa are the sudden onset, painless, apparently causeless, and recurrent bleeding. And in about 5% cases, it occurs for the first time in the second or third trimester or during the labor, especially in primary gravity that occurs. And in about 1/3 of the cases, there is history of warning hemorrhage. In 1/3 of the cases, there will be warning hemorrhage, which is usually slight, and the bleeding is unrelated to physical activity and often occurs during sleep. And the patient becomes very frightened on awakening to find herself in the pool of blood. The bleeding is unassociated with pain unless labor starts simultaneously. The obvious cause for the placental separation, such as trauma or hypertension, are usually absent. The first bout of bleeding is usually not alarming, but subsequent bout may be heavier than the previous one due to the separation of fresh areas of placenta. Usually, one third of the women will present before 30 weeks, one third between 30 to 36 weeks, and the rest one third after 36 weeks. Earlier, the bleeding is more likely to occur in major degree. However, there may not be any bleeding in the central placenta previa until labor starts. Asymptomatic cases may be detected by sonography or at the time of cesarean section. The general condition and anemia are proportionate with the visible blood loss, but in the tropical areas, the picture is often confusing due to pre-existing anemia. And then per rectum of abdominal examination, the size of the uterus is equal to the period of gestation, and the uterus is relaxed, soft, and elastic without any localized area of tenderness. Persistence of malpresentation, breast transverse and unstable. And unstable lie is common. There is also an increased frequency of twin pregnancy. The head is floating in contrast to the period of gestation. The persistent displacement of the fetal head is very suggestive. The head cannot be pushed down into the pelvis. The fetal heart sound is usually present unless there is major separation of the placenta with the patient is exsanguinated condition. The slowing of the fetal heart rate on pressing the head down into the pelvis. The slowing of the fetal heart rate on pressing the head down into the pelvis, which soon recovers promptly as the pressure is released, is suggestive of the presence of low-lying placenta, especially of posterior type. And this is known as stall-worthy sign. What is this? Stall-worthy sign. But this sign is not always significant because it may be due to fetal head compression even in the otherwise normal case. And in vulval inspection, only inspection is to be done to note whether the bleeding is still occurring or has ceased, the character of blood bright red or dark colored, and the amount of blood loss to be accessed from the blood stained clothing. In placenta previa, the blood is bright red as the bleeding occurs from the separated uteroplacental sinuses close to the cervical opening and escapes out immediately. The vaginal bleeding should not be done in a diagnosed or suggestive case of placenta previa. It may be done prior to the termination of pregnancy in the operation theater under anesthesia, keeping everything ready for cesarean section. So we should not do vaginal examination. And now we'll be talking about a confirmation of the diagnosis. And we have the dictum that is known as the painless and recurrent vaginal bleeding in the second half of pregnancy should be taken as placenta previa unless proven otherwise. So that is the case. An ultrasonography is the initial procedure either to confirm or to rule out the diagnosis. And we have the placenta for the investigation. We have the placentography, and it includes the sonography. Sonography is diagnostic technique of choice according to RCOG, and it provides the simplest, most precise, and safest method of placental localization. In addition, it is also helpful for accessing the fetal size and status. It also provides information pertaining to maturity and well-being of the fetus for guiding the management. And the transabdominal ultrasound, the accuracy after 30th week of gestation is about 100%. The false positive result may be due to full bladder, and the poor imaging could be due to maternal obesity and posteriorly situated placenta. And the cases of placenta previa detected in early weeks should be subjected to repeat scan at 36 weeks for detection of placental migration. As we have already discussed, there can be placental migration and placenta previa might resolve on its own. And in the transvaginal ultrasound, transducer is inserted within the vagina without touching the cervix. The probe is very close to target area, and higher frequency could be used to get a superior resolution, and it is safe, and it obviates the discomfort of full bladder, and it is more accurate than the transabdominal ultrasound. The complete placenta previa diagnosed in second trimester will persist into third trimester in 26% of the cases, and whereas the marginal placenta previa with persistent is only in 12.5% case. And we have transperineal ultrasound that is well accepted by the patient, internal os is visualized in 97 to 100% of the cases. The collar Doppler, the diffuse vascular lake with turbulent flow in the hypoechoic areas near the cervix, is consistent with the diagnosis of placental previa. And the 3D power Doppler is the best, and the hypervascularity at the uterine serosa bladder junction is diagnostic. And we can also do the MRI. It is non-invasive method without any risk of ionizing radiation. The dark intraplacental band are seen on T2 weighted image. MRI is better than ultrasonography to diagnose posterior placenta previa and placenta previa accreta or pancreta with bladder invasion. And the limitation of MRI is that it is more time consuming and it is expensive. And we can also confirm the placenta previa by clinical examination like double setup examination, vaginal examination, especially in the operation theater. And we can do the visualization of placenta previa on the cesarean section, and that's that. And we will talk about differential diagnosis. As we have said, abruptio placenta is one differential diagnosis. Placenta previa is oftentimes confused with other causes of bleeding occurring in latter month of pregnancy. The most common one from which it has been differentiated is about bleeding from premature separating of normally situated placenta, that is abruptio placentae. And we will see the difference between abruptio placenta and placenta previa in subsequent next video. And in the local cervical lesion like polyp carcinoma can be easily differentiated by speculum examination. However, both of the condition can also coexist. And now we will talk about complication. The maternal and fetal morbidity and mortality from the placenta previa is very high. In the maternal, during pregnancy, there can be antepartum hemorrhage with varying degree of shock, and it is an inevitable complication. With shock, it is inevitable complication. It will occur, and the first bout of hemorrhage is seldom severe, but subsequent hemorrhage may be very dangerous, and coexisting placental abrasion is around 10%. And the next is malpresentation. There is increased incidence of breech presentation and the transverse lie. The lie is often becomes unstable, and the premature rupture, either spontaneous or induced, is common. And during labor, there are various complications like early rupture of membrane, the cord prolapse. It is due to the abnormal attachment to the cord, the slow dilation of cervix. This is picture of cord prolapse. Slow dilation of cervix due to attachment of placenta on lower uterine segment, and intrapartum hemorrhage due to further separation of placenta and with the dilation of cervix. The increased incidence of operative interference like cesarean delivery, hysterectomy. Intrapartum hemorrhage, it is due to various other reasons like imperfect retraction of lower uterine segment upon which placenta is implanted, the large surface area placenta with tonic uterus with pre-existing anemia, the association morbidly adherent placenta accreta increta that might be associated, and the placenta previa accreta is serious complication that might lead to maternal death. Trauma to cervix and lower segment because of extreme softness and vascularity. And finally, the death is due to the massive hemorrhage during the antepartum, intrapartum, and postpartum period. The operative hazard, infection, and embolism are also the cause of death. And it should be remembered that because of antepartum anemic state, the patient may become shocked with relatively small amount of blood loss. Next is we have the retained placenta. An increased incidence of manual removal and add further hazard to the postpartum shock. The incidence of retained placenta is due to various causes like increased surface area, increased morbid adhesion. So that was the during puerperium. There might be complication like the sepsis. It is due to increased operative interference, placental site near to my vagina, anemia, devitalized state of patient. There is subinvolution and embolism. And we have the complication in neonate and fetus. As obstetric deals with two life, mother and the fetus, then the fetus will also suffer. One is low birth weight due to wet baby is quite common, which may affect of this is due to the preterm labor, either spontaneously or induced. The fetal growth restriction, repeated bout of hemorrhage, and while carrying on expectant treatment can cause chronic placental insufficiency. And the asphyxia is common, and it may be the effect of early separation of placenta, compression of placenta, or compression of cord. And intrauterine death is more related to severe degree of separation of placenta with maternal hypovolemia and shock, and death are also due to cord accident. Birth injury are more common due to increased operative interference. Congenital malformation is 3 times more common in placenta previa. And the fetal maternal and fetal morbidity and mortality from placenta previa are quite high. Now we will be talking about management of placenta previa. The placenta previa is one of the inherent obstetric hazard, and in the majority the cause is unknown. Thus, to minimize the risk, there are various the following guidelines are useful. The preventive measures like regular antenatal care to improve the health status of women and correction of anemia. Antenatal diagnosis of low-lying placenta at 20 weeks with the routine ultrasound needs repeat ultrasound examination and 34 weeks to confirm the diagnosis. The significance of warnings hemorrhage should not be ignored, and the woman is advised to avoid sexual intercourse or digital vaginal examination that could disrupt the placenta. And the color flow Doppler ultrasound in placenta previa is indicated to detect any placenta accreta. The color flow Doppler CD in cases with asymptomatic placenta previa is done preferably between 36 to 37 weeks, and in cases of placenta previa with complication like hemorrhage, delivery is done immediately regardless of gestational age. And MRI is superior to ultrasound. An MRI can diagnose posterior placenta previa, placenta accreta, increta, percreta with bladder invasion. The findings are dark intraplacental band, tenting of bladder, and uterine bulging. And at home, the patient is immediately put into bed rest. To access the blood loss, the inspection of the clothing soaked with blood, to note the pulse, blood pressure, and degree of anemia. Quick but gentle abdominal examination is done to mark the height of the uterus, to auscultate the fetal heart sound, and to note any tenderness in the uterus. The vaginal examination must not be done. Only the inspection is done to see whether the bleeding is present or absent, and to put a sterile vulval pad. And we have to finally transfer to the patient. While transferring the patient, the arrangement is made to shift the patient to an equipped hospital having facilities of blood transfusion, emergency cesarean section, and neonatal intensive care unit, that is NICU. The flying squad service is ideal for transfer of such type of patient. An intravenous ring or lactate solution drip should be started, and it is kept running until during the transport. And the patient should be accompanied by 2 or 3 person fit for donation of the blood if that is necessary. And admission to hospital, the all cases of APS, even if the bleeding is slight or absent by the time the patient reaches the hospital, should be admitted. And the reason are the all cases of APS should be regarded as the placenta previa is due to placenta previa unless proven otherwise. And the bleeding may recur sooner or later. No one can predict when it occurs, and how much she will bleed. So we have to admit every patient of the APS. Every patient of the placenta previa and APS, regardless whether that is bleeding is slight or absent. So all cases of APS should be admitted. And the treatment at the time of admission, the immediate attention is the overall assessment of the cases like amount of blood loss. We have to note by noting the general condition, pallor, pulse rate, blood pressure, hemodynamic assessment. Blood sample are taken for the group, cross-matching, hemoglobin, hematocrit, coagulation parameter. The large bore IV cannula is sited, and the infusion of normal saline is done. This is started, and compatible cross-match blood transfusion should be arranged. We have to give the 14 or 16 wide bore cannula. 14 gauge is orange cannula, and 16 gauge is gray cannula. And the gentle abdominal palpation to ascertain any uterine tenderness, and auscultation to note the fetal heart rate. And the inspection of the urethra vulva should be done to note the presence of any active bleeding. And the confirmation of the diagnosis is made from the history, physical examination, and with the sonographic examination. Next, we have the formulation of line of treatment. The definitive treatment depends upon the duration of pregnancy, fetal and maternal status, and extent of hemorrhage. So this is the flowchart from DC Dutta, and this shows the scheme of management of placenta previa. And here it is written that all APS placenta are to be admitted, as we have already discussed. First of all, we have to immediate attention like general and abdominal examination, clinical assessment of blood loss, hemoglobin percent, hematocrit, ABO and RS grouping, and resuscitation if needed is done, IV infusion, transfusion using wide bore cannula, and localization of placenta using ultrasound. We have already discussed this. And there are two types of management: expectant treatment or active interference. In expectant treatment is has been advocated by McAfee and Johnson in an attempt to improve the fetal salvage without increasing undue maternal hazard. The aim is to continue pregnancy of the fetal maturity without compromising the maternal health. The very vital prerequisite for expectant treatment are there should be availability of blood transfusion whenever it is required. Facilities for cesarean section should be available 24/7, 24 hours, and it should be necessary. And the selection of cases are in the suitable cases for expectant management are if there is no active bleeding and mother is hemodynamically stable, hemoglobin is more than or equal to 10 gram percent, hematocrit is more than 30%, and duration of pregnancy is less than 37 weeks. If there is active vaginal bleeding is present, and active vaginal bleeding is absent, and the fetal well-being is reassured, and CTG is also reassuring, and reassuring fetal heart rate. So in all this patient, we can do expectant management. And what are the things we are doing in expectant management? First of all, there is bed rest, the pelvic rest with washroom privilege, investigation like hemoglobin estimation, blood grouping, urine for protein add-on, periodic inspection of the vulval pad, and fetal surveillance with ultrasound at interval of 2 to 3 weeks. Supplementary hematinics like oral IV should be given, and blood loss is replaced by adequate cross-match blood transfusion if patient is anemic. When the patient is allowed out of the bed 2 to 3 days after bleeding stop, a gentle speculum Cusco's examination is made to exclude local cervical and vaginal lesion for bleeding. However, their presence does not exclude placenta previa. And the use of tocolytics like magnesium sulfate can be done if vaginal bleeding is associated with uterine contraction. And the use of cervical circlage is not done; it is not helpful. And RS immunoglobulin should be given in all RS negative women. So what are the things we have to do in expectant management? That is McAfee and Johnson regimen. Bed rest, investigation, periodic inspection, supplementary hematinics, use of tocolytic magnesium sulfate, anti-RS immunity, and no role of cervical circlage. We have discussed this all just now. And next we have the active interference. The active management, the indication for definitive or active interference is the bleeding occurs at or after 37 weeks. The patient is in labor. The patient is in exsanguinated state on admission. Bleeding is continuing and moderate degree, and the baby with non-assuring cardiac status. And steroid therapy if duration of pregnancy is less than 30 weeks. And in all these cases, ultrasound examination is done, and it is and it can be noted that expectant treatment is terminated at 37 weeks. And at 37 weeks, the baby is mature. Baby becomes sufficiently mature, and so that's why it is stopped. And after that, the ultrasonographic examination is done, and if the placental age is more than 2 to 3 centimeters away from internal cervical os, then the trial of labor is decided. The internal examination in OT is not done. And artificial rupture of membrane with or without oxytocin is done, and satisfactory. If there is satisfactory progress of labor, then we can do the vaginal delivery. If the bleeding continues, no labor is inserted, we have to finally do the cesarean section. And most women with low-lying placenta are also delivered by cesarean section. And placental age is within 2 centimeters. Again, we have to do the cesarean section. In majority of the women, we have to do cesarean section, as we can say cesarean. and vaginal delivery is considered only when the placental is clearly, very clearly 2 to 3 centimeter away from the internal cervical os based on sonography. Cesarean in women is done in all women with sonographic evidence of placenta previa within 2 centimeter from internal os, and especially it is indicated in the women with posterior thick placenta previa, and the most of the women with low lying placenta is also by cesarean section. And during the recent year, there has been wider use of cesarean section in an attempt not only to reduce maternal risk but also improve fetal salvage. And the cesarean delivery in cases with asymptomatic placenta previa is done preferably between 36 to 37 weeks, and in cases of placenta previa with hemorrhage, the delivery is done immediately regardless of gestational age. So that was all about placenta previa, and in next video we will come up with another important cause of antepartum hemorrhage, that is abruptio placenta. Thank you till then. Thank you and bye bye.